All right. Hey, everyone. Thanks for joining us at XPC Retreat. We're hanging out in a cabin in Virginia and all over the country on Zoom. And this is our first virtual rounds. And what we're doing is just chatting with people from different industries with different backgrounds about primary care. And I think a good place to start out, because so many people are interested in primary care, and there's been some discussion about what exactly primary care is. So I just want to throw out to the group, what is primary care? Allison, you want
You're gonna start with like this like non-answerable question.
exactly.
So I'll introduce myself briefly. My name is Dr. Allison Edwards. I'm a family medicine physician. Opened up a direct primary care practice in Kansas City in 2016, early 2017, and then recently sold this past spring and consolidated the practice with another one, and have transitioned into tech consulting for a company called Sesame, where our whole sort of ethos and motivation is to provide transparently priced, affordable healthcare to everyone nationwide. And so that's kind of my background. So I'm obviously trained in primary care, lived it, breathed it, did everything about it for 5 years solid, and continue to feel passionately about it. So that's setting. I mean, is that okay that I introduced myself? Like,
Yeah, that's fine. Well, we linked everybody on the LinkedIn.
okay.
Yeah, feel free to give a brief.
Nobody reads, you know, this kind of like nobody in here.
We should have done
like,
video intros.
Yeah, right. But anyway, I think primary care is fascinating to me because obviously in medicine, I went into it because I wanted to care for more than an individual. I wanted to care for a community. I wanted to care for the holistic being of, like, not the person, but the person, their context, their environment, their community. And so being a primary care clinician, I discovered that one-on-one intervention is important, and so important to primary care, like with a capital P and C, like the delivery of primary care to a person, like chronic disease management, acute care, urgent care visits, holistic continuity of care, all those things that we know lower morbidity and mortality. But also we're sort of designated with caring about social determinants of health and public infrastructure and all of these other things that contribute ultimately to the diseases that we manage in primary care. So that's why I laugh, is I'm like, it's this, but it's this, like it's everything, which is like exhausting sometimes, but is also why I'm here part of this conversation, because everybody here, doctors and beyond, contributes to what primary care really is. That's it.
Well, I love that overview. And I think, I, not being a clinician, can weigh in here. My name is Ed Melendez. I'm with Vita Health. I also advise startups, one in particular called Peer Collective that is focused on mental health. But my background is public and population health. I started with Louisiana Public Health Institute about 20 years ago, trying to integrate behavioral health into federally qualified health centers, a number of population health initiatives, as well as early HIT initiatives. And consecutively, I've worked quite a bit in digital health over the past few years with Vita, most recently, or currently, I should say. But I think the thing that, as you were talking about that, Dr. Edwards, was thinking about also the longitudinal quality of primary care that you kind of hinted at, like taking care of a whole community. And I think about, for example, like sort of the Cuban medical system with, a doc that is like living and breathing in that community for the entire time. And so when I think about primary care, I really do think about that longitudinal relationship on, as well, just to kind of add on to that.
Yeah, Kenneth, this is Dan McCarter. I'm with ChenMed, and we do full risk primary care advantage. I'm a primary care doctor, and I spent 27 years in rural practice and at the University of Virginia before I joined ChenMed 5 years ago. And I would just like to chime in what I think primary care is not. And so many times when I read business articles talking about it, they equate primary care with visits, right? And calling primary care based on visits is like calling a tire an automobile. I mean, it's more about relationships than it is visits, and visits can be a part of it, but that's not all of it.
And that's good. It's I think that's a good place to move into another question that we had, which is what do we need to unlearn about primary care? Like perhaps it's some misconceptions or something that we've believed for a long time, but really need to question. And I'm also curious to hear from some of the venture folk who aren't necessarily clinicians on what you think maybe primary care is or isn't.
Maybe I can chime in here. So, hi, I'm Jan Felix. I'm publishing a blog called Health Tech Stack, looking at it like at healthcare a lot through kind of the payer angle and the technology angle. And so I'm not a physician, so I'm looking at primary care a lot from a like, what can primary care do in order to reduce costs and improve outcomes? And I mean, both things are very tightly related. But I think one of the things that probably needs to be unlearned is exactly, I think, what we just heard about the visits. So, so primary care needs much more investment in order to be effective in managing diseases better, in like avoiding unnecessary healthcare utilization and decrease the overall cost of care. And I do think for that, you need to unlearn that it's like these 8-minute visits, but it actually is like a ongoing relationship that needs more investment. However, this also requires a different financing model because that type of primary care is much more expensive. And I think a big unlearn here is like that primary care is like a gatekeeper just for specialty visits, but actually can take more care of more conditions.
Yeah. Hi, I'm Hamali Patel. I'm a physician in internal medicine, double boarded in lifestyle medicine. I was a hospitalist, still do hospitalist work, transition into primary care. Now I do clinical design thinking at One Medical in chronic care management, building out our suite of programs and offerings in the digital health space. And I agree, Jan Felix. I think that I think historically, even amongst providers or young people in training who wanted to go into primary care, we've often been thought of as a referral mill. And you come to your primary care doctor to just get referrals and that's it. And as someone who sees it from the hospital standpoint, inpatient to then all the way on the outpatient side, it becomes very fractured. And so definitely unlearning some of the ways that you think about your own colleagues in primary care also can be really helpful. And then building out the longitudinal relationship, not making it about visits and time spent with patients, but the quality and that you're building a relationship. And so maybe upfront, you're spending a little bit more time with your patients because on the back end, that'll mean less time because you know them, is actually something that's really important that I don't think is really emphasized enough in traditional practice. And I'm now 10 years out of training, so that might be different, but the way that I kind of grew up or trained, seeing primary care. When I decided to go to medicine, I actually wanted to go into primary care, but then being in training, seeing how my primary care attendings were managing their patients didn't really make it seem like it was sustainable for me. Stacks of papers where you're like literally filling out disability forms and pre-authorizations and all those things, like forget it. I'd much rather be in the hospital where things are a little bit more fast-paced. But now coming out on the other end, seeing what can be done, I think is extremely exciting. But I think there's a lot to unlearn in regards to folks wanting to go into primary care in training, but being dissuaded because of the current climate.
Awesome. And I think there was a mention about just like primary care needs to be funded better. And so one of our other questions was, if you had $1 million, which understandably in the health tech and investment world is pennies, but what would you do with that money if you were to invest it and really make something change in primary care?
I'll speak up. So I'm a physician, angel investor, advise a few startups as well. I'm looking at different payvider models for primary care in particular to incentivize prevention. It's incredibly difficult to incentivize prevention as preventive behavior is difficult to do. The model I'm looking at right now, and this is for a startup I might launch as an insurance carrier, is paying people to take up preventive services. It makes sense from the payer perspective. For example, lung cancer screening is at 4%. It costs about $250,000 per patient for late detection. So the finances make sense, but it's just incredibly difficult to incentivize the preventive behavior. I'm not quite sure how to gamify it. And there are insurance carriers who have tried paying people to do screening tests and they still don't do it. So I think it's a very difficult problem to solve.
Just as a point of clarification, are you talking about paying the patient or paying the providers to do the prevention?
Paying the patient.
I can jump in here. Hi, everyone. Jeff Yuan. I'm from Taro Health. I am not a clinician by background. So Taro Health is a fully licensed, fully insured health insurance company here in the state of Maine. We sell health insurance plans on the individual and family market as well as small group market through the Obamacare market here in Maine. It's a state-based exchange called coverme.gov. And the way we structured our plans is actually around folks like Dr. Edwards, where we partnered with independent direct primary care physicians exclusively. If you know anything about direct primary care, they historically have not taken any insurance. The irony of what we've done is we partnered with independent PCPs and we built an insurance plan around a bunch of physicians who left the insurance system. So we're excited to be out there. I think on the $1 million question, I guess the obvious answer for us is putting our money where our mouth is when it comes to investment in primary care. So when you buy our health plans, you get a DPC membership for free. It's included in the insurance premium. And we've also priced our products exactly the same way, working with actuaries as our competitors as well. Our investment in primary care on a per member per month basis is about 2.5x more than the BUCAs in terms of a fee for service basis, weighted average across their entire population. That's because the primary care membership is about 2.5x more. And so the bet we are making, frankly, is that the direct primary care experience will actually not only make up the investment we are making from an actuarial perspective as we think about our economics with medical loss ratio, but also go even further in reducing savings when it comes to RX, ED utilization, specialist utilization. So for us, we have come out swinging as a full insurance carrier, betting on primary care and making that PMPM investment.
I would love to ask you, like, what do you think are the biggest levers that a DPC can do in order when it comes to cost savings?
It's a lot. I think anecdotally, there's a lot of stories of the person who has a stomach ache and walks into the ER, and that's true, but it's not necessarily the silver bullet. There's a mosaic, I think, of interesting ways where urgent care utilization, specialist utilization is our hypothesis that it's going to go down. I also think the comprehensive nature of direct primary care, a skin biopsy in the office instead of a referral to a derm, the cheaper labs that they can do because of some of the relationships that they have with client bill. There's a lot of interesting things that remove necessary referrals to facility-based areas. That I think in aggregate is our bet that will make up our investment on a PMPM basis.
And I'll add to that, as a clinician practicing in that model, it's pretty impressive how much you can decrease people's reliance on higher priced care when you actually provide good primary care. Like if you have a long-term continuity relationship with a patient who trusts you, they're going to come to you first. And if you actually employ the training you received as a family physician, as a primary care physician, you really do not need to refer people to specialists unless they're in a state of flux, right? Like something needs to be tweaked, like you really do want a specialty opinion, but like maintaining somebody on their levothyroxine for, hypothyroidism does not need specialty referral. Like maintaining somebody in their type 2 diabetes does not need specialty referral. The biopsy is a great example that Jeff brought up. Like you don't need to if you send somebody to derm, the first thing they do is a biopsy. It's like, just do it in the primary care office, save the person time, money, etc. So you can do so much more in primary care if we just, to Jan Felix's point, if we change the economic model and we incentivize primary care doctors to actually take care of their patients.
Maybe an interesting point here is also like you have to then really unlearn kind of the training, right? Like what are the aspects that you train primary care doctors to do, and like that they are aware that that's something they can do.
Well, and the issue is give them time to do it. because so many times in the fee-for-service models, when you're trying to see people in 10-minute visits, whereas if you're in the DPC or like us in the full risk model, where we have smaller panels of patients, it's not a big deal to create some extra time to do that. So it's not about just getting on to the next patient. I love what Jeff is talking about. I've been thinking about that for a long time, and I'm assuming you're using high deductible health plans so that people can get the HSA and pairing it to that. The only thing I would think is maybe partner that with what Rashad is talking about and paying people to get their preventive, have some incentives or gamify the prevention so that they would actually get that. And I bet you'll actually save money, because that's essentially what ChenMed does. I mean, we spend quite a bit more on primary care, but we have 30 to 50% fewer hospitalizations, and that's where the money comes from. So that I think it'll work. Are you publicly traded by any chance? If you are, what's your stock symbol?
No, we're a startup. We're just getting up and running. But
I'm sure Jeff would be happy to connect with you about further funding.
Yeah, we are high deductible plans for the most part. They're not HSA included because we have $0 primary care in our plans. And that's, if you know a little bit about the gymnastics around HSAs, you can't actually compatible have a $0 copay primary care plan alongside an HSA plan. You could maybe hack it with a $1 copay or something like that. Yeah, I mean, I think, this is the big bet we're making in terms of as the health insurance carrier, having 360-degree visibility of the claims as well, and being able to track that to really understand and measure the impact of what comprehensive direct primary care can lead to downstream.
But that's actually important because younger people are getting sicker, right? Like, we've never seen the level of chronic conditions come in a younger populations. And a lot of these folks are on high deductible plans. And so being able to allow them to get the care that they need without minimizing the amount of referrals is actually something that's super important, because they will add up the cost in their head, and they may defer care because they can't afford it, don't want to deal with it, don't want to spend on it. So the gamification is interesting from a prevention standpoint, but I wonder if that's even necessary, more so attaching it to kind of short-term incentives to the patient. Like, so often we see members come in and they're complaining about hair loss or fatigue, and it's all tied back to some sort of chronic underlying condition that they just haven't been diagnosed with, or they're too young, and so it's been dismissed. And so when you discuss, well, let's do some of these preventative measures, let's check certain things, and it's serving your bottom line in terms of prevention, but it's serving their short-term, why they came in the first place. I think it goes a long way to then also getting buy-in without necessarily having to offer cash to the patient. I would rather see the money being diverted to the providers taking care of those people.
Well, in terms of that $1 million question, I think one of the things that I'd be thinking about is, how do we educate patients to be better consumers and develop that more consultative relationship with their PCP? Because, we've talked a lot about, I think this idea, that Tara is working on is brilliant. I think we've seen in the health sharing ministries, this kind of where they're putting a bigger onus on the member to actually ask questions about, what are the costs going to be? What are the trade-offs? And if we can really start to build that relationship with the PCP, where they become the person who says, for informed consent, for thinking about side effects, cost, and having all of those conversations. I think the CVS health hubs actually work really well in some ways because of this concierge model, where it's just someone who walks you through your insurance, and has a menu of actual costs behind them, so that the patient is really informed and knows right up front, no surprises. How will this hit my HSA or whatever that is. And so I think that's where I'd like to put a lot more of my energy into, is like making patients like more empowered consumers. And that's a complicated thing. We have to unlearn so much about this relationship that we've had, you know, as patients.
I find this super interesting, and I might like disagree with you a little bit here though, because it's always like a lot of people are just very unengaged in the healthcare, especially when they're healthy. Like why do they need to like learn all the ins and outs of their insurance if they are not like if they don't really utilize the system? So I think there is like something around like and everyone is talking about patient engagement, or we need to get people more engaged and get them more in. I think and I think the role here is a lot on the payer, or like whoever provides the healthcare to them. So there needs to be like a few trusted entities that whenever there's a problem, somebody can go. So I think instead of like having a push model where you try to educate everyone on everything, you need more of like, oh, I have a problem, like please fix it. And I think the current system just doesn't have that. Like the hotlines in the health insurance carriers are horrible. It takes forever. And
that's the Band-Aid that CVS is trying to put on that same sort of thing with the health hubs, right? Yeah, absolutely.
Right. So I think that's probably more model that we need to have more. Yeah, and I think primary care doctors play a big role here, and I think maybe also a role of like understanding insurance and being able to explain this to their patient, what that actually means for them. So having a financial responsibility also for their patients.
Mm-hmm. Yeah, I would love to chime in on the innovation front. My name is Dr. Raihan Faruqi. I'm based in New York. I'm trained as an internal medicine physician, left practice 4 years ago to come work in early stage health tech as an operator, advisor, and a consultant. Currently the head of medical and clinical affairs at Guaranteed. We're a VC-backed startup in the tech-enabled in-home hospice and palliative care space. And when I was hanging out with Paulius in Vegas, we discussed what kind of patient and family empowerment looks like and sounds like. And we kind of ping-pong two ideas, which I'd love the group to kind of think about in terms of just primary care enablement. How do we enable patients to practice at the top of their license? And how do we enable family and caregivers to practice at the top of their license? And I think why that's important is, I think in primary care, there's big macro problems that I think are largely unaddressed right now. There's obviously the EMR and vendor fatigue. There's also the notification fatigue. And we've been discussing, hey, should people be paying $60 for a MyChart message? And I think that's just kind of the Band-Aid in terms of the problem where, you know, as we have care demand increasing across all verticals and demographics, and we have supply of providers plateauing and actually now decreasing, we have this gap. So I'm wondering, how does digital health enable that with kind of better patient education, just helping patients take care of themselves? You know, we have consumers who are going online, they're going on WebMD, they're just Googling what to do and they go do it themselves. So can
say that I was like, they have Google. What's your problem?
Yeah, right, exactly. But you know, so when we think about unlearning primary care, can we help people treat their UTIs? Can we help people treat their pink eye? Can we help people treat, you know, their URTIs? You know, does that require an in-person visit? Does that require a video visit? So how do we really enable low acuity care to be taken care of at home, or even enable the family member to be the frontline provider and alleviate some of that burden, save our primary care providers for the sickest, most expensive patients, your polychronic, polypharmacy, you know, 85-year-old frequent flyer. So I think that's what I would love to see some innovation, you know, spending go into when we think about kind of virtual peer support. Again, we think about these kind of wraparound service models with non-clinical staff at the front. When patients are calling the office or, you know, texting the office through MyCharts, is that a care coordinator? Is that a health coach? Is that a care concierge? How are we thinking through building an entire new workforce of non-clinical staff that can help alleviate burden from nurses and physicians? Because what I'm seeing is that we have NPs and PAs and MDs who are leaving the field. They're not coming into the field. So I think that is kind of a big macro problem where I think we need a lot of investment in.
Yeah, I think looking at the ed tech space in terms of how they have started to allow folks to learn is actually something that, as I agree with everything that you just said. I mean, I think patients need to become more of advocates around simple healthcare issues. I mean, when we were younger and you had some like problem, I'm sure none of us were really being taken to your primary care doctor. It was, you know, whatever your parents had told you, or just kind of get over it. And you did. Now what we see is a lot of reactive care, like the slightest things, and you're coming in. It leads to more episodic care because for a provider, when you're seeing those patients, it's also not as meaningful, I think, or sometimes it can be dismissive. And so I think giving a little bit more attention to the education about it in a correct way so that they're not coming and looking up something on Google and seeing like the worst case scenario when it's just like you're dehydrated and that's why your urine's a little bit more concentrated, I think can go a long way with just kind of empowering the patient to somewhat take care of themselves and come in when something is really going on or get evaluated more comprehensively.
Yeah, I love these perspectives. I wanted to touch base on something you said about the MyChart messages, and of course we've all seen the news, I'm sure, about perspective about maybe even charging for MyChart messages. And I think it's just this additional evidence of this previous methodology we had where we thought about the barriers and the threshold that it took to connect with your primary care doctor. And that's now we're seeing that again, where we've tried to move away from that model and increase access. Now we're thinking about providing patients with the need to think about, again, the mental gymnastics around, can I afford this? Can I afford to touch base with my doctor? Can I afford the copay that's going to happen when I go to them, see them in the office? And like, how do we continue to move away with that? It's this access and threshold balance that we need to continue to work towards. And that's just that, seeing that news and maybe that perspective about charging for even something as simple as that, which these portals were initially made to increase access, and now we're going to charge for them. It's just so backwards to me.
Well, so I think this is a really like central part of primary care because it's a business. Like we're all on here as people who work in businesses. Like healthcare is a business, and it doesn't matter how you feel politically about, you know, anything from single payer to privatization. Like it's always going to be ins and outs. Paychecks need to be written, money needs to be made. And so when you think about like increasing access via portal, via messages, right? That's a true use of time. And that physician's not being paid for that time. And as Dr. Faruqi already said, like clinicians are leaving. Like we're losing clinicians because they get tired of working for free, frankly. And what's also interesting that I want to bring up in this whole like conversation about access and changing the economic model and sort of like, how do we create a patient who is a consumer? I think it's important to realize that like the American Academy of Family Physicians, for example, continues to lobby for complete coverage of primary care visits within like any insurance model, which is sort of disincentivizes the patient to behave like a consumer. Because if primary care is free, which is the language that patients use when they aren't, you know, exchanging money or getting a bill for a service. I mean, they're paying for it through the premium. But like when it's free, you don't act as a consumer. And so then it creates this really weird subconscious thing where number one, overutilization could happen, to Dr. Patel's point. And then number two, it kind of systematically devalues the primary care experience from like a consumer standpoint. Our perspective on Sesame is really interesting. When we do user surveys of like, how much would you pay for a primary care visit? People tend to essentially, you know, the law of averages, you know, some are really low, some are really high, but people tend to say like around $50 because that's what they're used to paying for their copay. And so it's like the consumer thinks a primary care visit is worth 50. And if we start to include it as our trade organization wants it to be included, people are going to value primary care at 0, which is exactly kind of the opposite of what we're all discussing about empowering the patient to be a consumer, which kind of feels dirty because like I'm very much a bleeding heart liberal where I want everybody to get like really great care at no cost. Like that's really what I want. But ultimately, we're in a business and like and we have this whole system that's way too expensive. And until you create like consumer type behaviors and apply downward pressure on prices, like we're just going to be where we are. So I wanted to raise the point of like, isn't it interesting that our trade organization wants to make it so that consumers essentially devalue primary care?
Well, I will be the devil's advocate here.
Yeah.
In a group that so we take full financial risk, hospitalization, we take A, B, and D risk, and we don't have any reinsurance. So we take all the risk. So what we have trouble doing is convincing our patients to come in frequently enough to see us. And we don't ever want to put a block between the patient and their PCP. So the question is, what is the business model? Because again, you're talking about a business model based on visits, and we're in a business model based on keeping patients healthy and out of the hospital. And that's really what we're focusing on. And if patients trust us and call us for everything, then that's the important part. Now, the issue you're talking about is you got to be careful not to turn yourself into the McDonald's short order cook, right? They want antibiotics because they've had a sneeze for 2 days. That's not good for public health. So how do we have that? But I think as primary care, primary care is the only specialty shown to improve mortality and lower cost of care. And it does so more so than any specialists do. So I think we've got to figure out a way to come up with a business model that rewards primary care instead of us trying to fight in the specialist fee-for-service built business model. But anyway, I'm sorry. I'll get off my soapbox.
I just have one. Oh, go ahead.
Okay, no, go ahead. Go ahead.
Oh, sorry. I just had one comment to Dr. Edwards. I mean, I agree that treating patients as consumers is probably not maybe the best idea, just given all the points that you just raised, but point solution companies are treating patients as consumers, and that's actually causing worsening fragmentation of the system. Now you have people getting their metformin, not getting anything else checked. Those folks are going to actually end up in the hospital and with a bigger problem coming out. So we're actually changing around the behavior of the way people are thinking about their health, which I think is extremely dangerous. And so how do you contend with that? Because patients are already being considered as consumers.
These are such all great perspectives. I would love to know, I think seems like a lot of people have said that longitudinal care is really the importance of primary care, removing it from this encounter-based philosophy into seeing the patient across, larger data sets and longitudinally. But if the cost is zero, does that increase our ability to create these longitudinal views of patients? Or Dr. Edwards, to your point, is it actually going to disincentivize because it's just like I don't need it? I'm not a consumer of healthcare, maybe be prohibitive in that way. And I don't know if does $0 create a better exchange in this longitudinal view, or is it actually charging what's realistic? I don't know, but I'm loving this discussion.
So Rashad, I think you had something you were going to chime in with.
Oh, I was just going to say I'm a big proponent of us letting go of control of needing to see patients for everything, of AI and clinical decision trees replacing us completely for certain tasks. K-Health does this to an extent where if it's a refill for, say, Ramipril and the renal function's intact and they don't have any new symptoms, I don't need to see them. I think the state medical boards should give a license for these algorithms to prescribe medication. I was in discussion with the Canadian, so I'm from Canada. I was in discussion with the Canadian boards, and some are open, some aren't. I think the future of primary care is patients are consumers, whether we like it or not. Unfortunately, once these companies like Hims and Romans and Cerebral out of the bag, patients are used to that experience, and they will hesitate to go to an experience of where they need to come see us. I think we need to decide or figure out how often do we need to see the patient, and say they come in for a refill of metformin, how can we triage them beforehand to see, do we need to see them? And what labs they need and things like that. But I think a lot of this can be automated. And again, this is on the basis of if AI can replace me and do a better job than me, it should.
You're going to hate this, but my AI in our clinic was my nurse. which is so not AI, but like, but to your point, like I would lose my mind if somebody had an appointment blocking time on my schedule for a med refill and they were stable and, you know, well controlled. And like you said, like, I was like, if that ever shows up. So like we went through this whole algorithm to make sure that that never happened, but we had continuity. We knew the patients, you know, they were with us. Like there was all this sort of like ownership of that whole thing. But anyway, our AI was very human.
That's perfect as well. The point of AI is to increase access at the lower cost of care delivery, and a nurse or even an LPN would be a lower cost, or even a medical assistant.
Yeah, although I can tell you, and I'm probably far and away the oldest person on the call today, but I also am on the Legislative Affairs Committee for the Virginia Academy of Family Physicians. And there are a bunch of the older doctors that are terribly upset because somebody came up with the idea of allowing refills to go for 18 months or 2 years rather than stopping it at a year. And they're like, well, how are we going to get paid if we don't stop this and make them come in? And so that is, I'm not sure that the AAFP or the medical societies are going to solve the problem. I got to say, I'm much more hopeful listening to you all talk than I am listening to the AAFP talk. So I want to. If I had $1 million, I'm putting you in charge and taking it away from them.
I didn't mention I'm the medical director at Memorial Health, and we do a lot of this work to automate these messages that happen we work with primary care clinics, so trying to leverage a lot of VBC models. And it's still a challenge, right? It's trying to find the balance between automated messaging that still has some sort of empathy to it, but allowing patients to still find a way to connect with their providers and feel that human interaction. And it's a balance we're still trying to strike. But it has been interesting in the research we've done. We did some intercity Philadelphia research, broad range of demographics, and we found that the usage of our platform was pretty equal across all socioeconomic statuses and demographics. Just showing that I think that there was actually an increase in access because it was just a lower barrier of entry than they had before. And there's still a lot of work to be done around that, but I think there is value to that. It's just striking the right balance, because a quote chatbot alone is not going to solve all the problems, and we can't swing the pendulum too far in that direction. But it's finding that balance.
So on the topic that we've been talking about, I'm curious to know what you guys think about the big news, obviously, Amazon Clinic launching and actually doing, they're not just doing the basic telemed like UTIs, URIs, and that kind of stuff, but they are also in the business of refilling the chronic medicines, like that's been mentioned. And then the other thing you guys had talked about previously was just like patients wanting things, which is kind of consumer care versus patients needing things, and a bit more healthcare. And so Roe, I learned recently, you know, they started off with like hair loss, ED, stuff that people want taken care of. And now they're trying to attach some preventative stuff. So at the point of, hey, my hair's thinning, they're like, oh, by the way, you're over 50. Do you want a colonoscopy? So I'm curious to know what you guys think about these companies kind of working backwards almost from where traditional primary care is.
Well, I'll kick it off with, you know, my opinion about a lot of these direct to consumer models right now is that they're fairly irrationally funded, in the sense that they have incredibly high sort of acquisition costs. It's really tough to do anything except be sort of, you know, a vendor for a specific condition or something like that. But that said, I think they are starting to change the behaviors of consumers. And as we're seeing sort of a reduction in employer-based insurance, we are seeing more people who are either on high deductible health plans, health exchange, where they're just sort of forced into knitting together these solutions for themselves, whether, you know, and so they will choose that easy access, you know, and so while a year ago, virtual primary care was, sort of a non-starter because most people just couldn't wrap their heads around it. We're starting to get to this point where people are going, yeah, like with a K-Health, or is there an algorithm that could walk me through whether I really need to see a doc or not? Those are really big shifts we're going to see in the marketplace, where individuals are just going to be figuring it out for themselves. And so what do we want to do here is, do we want to be the honest brokers in this, or, kind of take those on, sort of hoping for regulation or something like that to address it? So that's kind of where I kind of see it right now. I think we're in a real big period of flux.
I'll just add, I think the growth of the gig economy will add a big market gap in people who are not insured through their traditional employers. Yeah, I think there's a big opportunity there.
We touched a little bit barely on like the policy side of things, right? I don't know how much you guys are tied into just legislation and rules and regulations. Healthcare is a big one. Are there any big policy things that you guys are interested in looking at, like big laws that should be passed, or maybe some that you think we need to get rid of to really expand and grow what we can do in the primary care space?
Real quick, HSA use for direct primary care memberships would be huge, but
That's a great point.
we don't
Yeah.
need to talk about that. That's a long conversation.
I like to see, I think what's happening right now with compact licensing for nursing and for PAs should be translated into physicians. I mean, I think that as a physician, wanting the flexibility to be able to practice and seeing such a cross migration, especially during the pandemic, of your patients now going to Austin or New York or wherever they might be, to not be able to see them in the way that you are now able to see them via telehealth, because you simply can't prescribe for them, I think is frustrating, especially when you're seeing these mid-level providers being able to. Like, I have no idea why. It makes no sense to me why that is allowed when physicians cannot do that. And I think that then it contributes to all the things that we've just been discussing around patients needing to kind of figure it out for themselves. If they want it, they need it. They're not going to try and waste their time continuing to see me. They're going to go and say, well, Dr. Patel prescribed me X. There's this company that's prescribing it right now, and I'm just going to get it because I don't want to establish myself with a new primary care physician. So that's one that I would love to see. And I know that there's talks about it. I'm looking forward to seeing how quickly that can actually start getting moved forward.
I would actually love to hear more about HSA and DPC. As a Canadian, I know a little bit because I invest in US startups, but I would love to hear more about it.
Yeah, I think that whole thing is a gray area, and we can continue that discussion in a different venue.
Actually, it's not really gray anymore. Like, the IRS pretty much said, this is not an allowable expense.
Mm-hmm.
Yeah, it's very much thank you to some very loud DPC doctors. The IRS weighed in, and that's what they said.
What was the reasoning behind it?
So the IRS, it's an IRS rule, because HSAs, the HSA conversation is a tax conversation, and so the IRS weighed in on what the acceptable uses of HSA money is for. They have a whole list, and for a really long time it was gray because it said that you couldn't use your HSA money for memberships. And I think the implication of that was gyms and things like that. It did, however, say that you could use your HSA money for doctor's visits. And so then DPC for the longest time was in this gray zone where it's well, you are paying for doctor's visits via a membership. So you're taking one from the okay column and one from the not so okay column. I think this was 2 or 3 years. It was during the Trump administration. The IRS finally weighed in and basically said that because DPC is similar to an insurance product and you can't use HSAs for insurance products, you can't use your HSA money for a DPC membership. Now, that being said, to my knowledge, no consumer has ever been fined, or the IRS has never audited anyone, and nobody's ever said, oh my God, here you are using it. So people do it all the time because they put in a bank number into our system, and like I don't know if it's an HSA or not. So it happens, but it's technically not allowed per IRS regulations. That's like the high level.
The big one is health data privacy. I think as data collection online has grown, states have begun enforcing abortion bans, cyber attacks have grown. HIPAA is a 1996 law. It doesn't cover data collected by health apps. It can track everything from weight loss to pregnancy, even like online web searches for symptoms, illnesses, or treatments. Apple Watches, Fitbits is unprotected. So that can be sold or shared without the patient's consent. So there's a couple of acts that are on the docket right now that Congress is looking at that I think will need a lot of like really urgent movement on.
Dan, I think you're muted.
I don't disagree with you about protecting that, but I would also like to see the ability, and I'm thinking back with my time at UVA, is the inability of people going to different health systems and sharing their data. I've found it just completely crazy that I've got a little plastic card in my wallet and I can basically walk up to a wall in pretty much any country in the world and stick that card in it, and it will spit currency out at me, and it will know what bank to take it out of. And nobody really thinks anything's more important than their financial confidentiality. But yet, if I have a chest x-ray done at an HCA hospital and go to a Bon Secours hospital, they don't have a way to electronically look at the results of that, even if I want to give them permission to do it. I think somehow you've got to put the confidentiality in the patient's hands rather than leaving it in the provider's hands, because a lot of money is being spent on that and wasted on that.
Yeah.
Can I ask, how does it work in Canada? Because like in my mind, this isn't a problem in Canada, but I think I might have made that up.
So we have provincial health insurance plans which cover almost everything, but they don't cover things like dental, physio, mental health counseling, optometry. So yeah, in Canada, access is more of an issue. So about 20% of Canadians don't have a family physician, and the average wait time for a family physician is about 3 to 4 weeks, or say an orthopedic surgeon is about 12 to 18 months. So it's a different set of problems, and I'm not sure if the Canadian system is better. I think our health outcomes are quite a bit better, but that's more to do with culture and a better safety net for our low socioeconomic status population.
But as far as like acts, like ownership of acts, or like the record and like sort of that information, does that live with you, or does that live with like a clinic or an entity?
So it depends. It doesn't travel with me. It can travel with me if I own my own clinic. Some physicians do, some physicians get together, but we don't have these big clinics outside of residency programs in Canada.
And then if I'm not mistaken, at least the last time I looked at data sharing in Canada, it was provincial sort of master databases of patient data, and then those were federated up to some sort of a national record. Is that still kind of the process?
For all intents and purposes, there is no data sharing.
Because of the provinces just...
In theory, yes. Accessing the data is a different question.
Interesting.
Yeah, so this pharmacy data is shared in British Columbia. Some lab and imaging data is shared in Ontario. So it's province specific, but the notes are not shared anywhere.
Well, I think there are two issues in the US with data sharing. And I think one, is related to the need to modernize HIPAA, since I think much of the protections that were in place with HIPAA around data sharing really had a lot to do with the underwriting process in the past for health insurance. And because ACA, thankfully, has really made that a non-issue any longer, there's really little penalty for your health information to be out there. You know, the two concerns you would have are, you know, underwriting, you know, concerns, or an employer choosing not to hire you for fear that you would be expensive, right? Well, these are essentially illegal. It's very rare that people would, you know, kind of tackle that. So, you know, there needs to be some mechanism for making that more easily portable for the patient today. Because, you know, if you find out that I have, you know, some high cholesterol or something like that, it's, you know, I'm not embarrassed to tell you all that that is my only health condition right now. You know, or, you know, we've lost a lot of the stigma about talking about AIDS or HIV status or, you know, other chronic disease. So it just feels like it's an antiquated model. Now, the other issue is, do you as the clinician trust the data that is in your EMR from another system or another, you know, entity that you don't know? And they're kind of, you know, that's what we struggled with in HIEs in the past, was simply, how do I flag this, that this information came from another facility? How does that factor into your decision making? So those are really kind of the challenges, I think, with this portability issue.
I don't think that would factor into my decision making as a clinician. I think data is data to an extent, and there is good objectivity in most medical data. But that's my personal opinion.
Mm-hmm.
I do want to shed light on another regulatory issue, and I think this is a lot around antitrust, because so even as a payer, if you want to bring on more DPCs and want to put more emphasis on primary care, in many markets in the US, this won't work because most primary care doctors are owned by large hospital systems. So, and they have like a very different incentives for these groups. They want that referral mill to work, and the reason why they expanded is that. So I'm really thinking, is there like something around prohibiting health systems to own primary care doctors so that like you incentivize that? I don't know whether I have this fully thought through, but like I do think there's something around also getting more competitive around the contracting process with physicians, so that physicians can choose who to contract with, and it's not up to the health system on who they take on or not, because a lot of the existing contracting systems just prevent payers or modern payers to build these more like direct contracts, easier ways of like how to integrate newer models into their benefit design. So I think those two aspects, like easier contracting with providers and creating some standards here, as well as like separating kind of primary care and specialty care, I think is one of the fundamental reasons why like it's not taking off to the extent that it could.
So, Jan Felix, just to clarify that, you're talking about hospital systems owning primary care, but there's also the idea of like the insurance companies owning physicians, right? Like United being the largest employer of physicians in the country. Are you talking about just like regulating things where the incentives may be malaligned, like the carriers owning the physicians, or just like separating primary care out from the hospitals so that they're not used as referral mills?
I think it's a very good point. I think I mostly thought about the first one around like health systems owning primary care doctors. I think it's interesting, like on the payer side, I do think like my first reaction would be that actually payers and primary care doctors are aligned in their incentives. They kind of want the same things. But there's probably more to uncover. What if they own the whole stack? But I mean, in general, like the pay-by-the model, like Kaiser and the integrated delivery network, where you align like the financial incentives and the care delivery, kind of works. So I think it's that the second one probably is not as bad.
All right. Very interesting.
And I know that like DPCs are actually trying to build their own health plan. So it's like the other way around, right? Like so hey, I'm a provider. Can I actually take on more risk and build a plan around it? So that's exciting as well.
Yeah, I'm sure Jeff has opinions on that as well, given what he does.
Yeah, I mean, we're early, right? And so I think, you know, there's permutations of this model over a long period of time. At least for us, we have no interest right now in building our own clinics. In our V1 model, we've really built the whole plan shoulder to shoulder with independent physicians. I think one of the kind of core philosophical beliefs of, for us as a company as well is we believe in the DPC model. One of the hardest things, and again, Allison knows this well, is patient acquisition, right? Because people are brainwashed to think that the only way they can get primary care is through the vehicle of insurance. And so they have to go out and convince people to pay out of their own pocket in addition to paying for an insurance premium. And so for us, when you think about physician burnout and some of these other downstream effects, some of the highest activation energy barriers for people to not only get out of the hospital-owned PCP practices, but also to create direct primary care practices is patient acquisition. So there's a bit of a, you know, as we all know, healthcare is cyclical. And I think there's a different infrastructure and technology stack over the last 2 decades that changes a little bit of the paradigm. But a lot of what we are trying to do is hitting the reset button, where if we are successful, we actually can be a catalyst for more primary care physicians to open up DPC practices because we are a new patient acquisition engine for them. And that de-risks their ability to go kick off that flywheel and get out of the hospital-owned kind of situation and support more independent physicians.
And I'm going to add to that that same inertia also helps bring people into primary care and helps keep people from leaving, like, and clinicians, it helps keep clinicians from leaving when they have, you know, all the things, like they have a practice that aligns with their values, that compensates them fairly, that respects their time, that creates like a community and all that stuff. Like it creates a better work experience. So actually that helps like beef up the primary care infrastructure as well.
Yeah. And on the topic of respecting time, we are at the top of the hour. So, you know, we'll keep this Zoom on. I'll stop the recording, but if anyone wants to stick around and continue chatting, feel free to. But I appreciate you guys all coming on today. This has been awesome, and I hope you guys enjoyed it as much as I did. You know, the whole point was just to get together, just really intelligent people and really innovative people that Paulius and I know and like, and we wanted you all in a room to just chat and hash out some big ideas. And you have each other's LinkedIn, so hopefully this leads to some connections as well in the long term for if you thought somebody said something interesting and wanted to connect. So I'm gonna go ahead, stop the recording here. Thank you guys all for joining. If you gotta go, it was great seeing you, and if you wanna stick around, feel free to do so.